Good afternoon, everyone. I am Dr. Sivaperumal, working as an assistant professor in Department of Pediatrics. Today's topic is perinatal birth asphyxia. Outline of the today's topic is we are going to see following topics, which include introduction, definition, etiology and pathophysiology, clinical features, investigation and treatment, and outcome. First, we are going to see about introduction. Introduction. The incidence of perinatal birth actually is 1.5% of the live birth, and also it is responsible for 20% of the perinatal death and 9.4% of the total under 5 mortality. Before that, we should know what is perinatal period. Perinatal period is include from 22 weeks completed gestation age to 7 days after birth. If anything happened during that period is perinatal death, it is birth is responsible for around 20% of the cases. And also, NNPD reported the birth asphyxia is one of the most common cause of stillbirth. Approximately, it is seen in 45% of the cases. And also, the incidence of birth asphyxia higher in mother with diabetic, gestational hypertension, and if they also seen in condition like breech presentation, post-dated gestation, and IUGR babies. After introduction, we are going to see about definition. And definition is most important in perinatal asphyxia. So many definition will be there. Before we going to definition, we should know difference between hypoxemia and hypoxia. What is hypoxia means? Decrease oxygen level in blood is hypoxemia. Decrease oxygen level in tissue is hypoxia. So you should know the difference. Ischemia means decrease blood flow to the organ. And what is perinatal aspects? Hypoxia or anoxia means complete or partial absence of oxygen in the blood or brain is called perinatal hypoxia. Perinatal ischemia means reduction or cessation of blood flow to the organ which compromise both oxygen and separate delivery to the tissue. After that, we are going to see about perinatal asphyxia. In this perinatal asphyxia, there will be defect in gas exchange. Because of that, there will be hypoxemia and hypercarbia, which occur mostly during peripartum and intrapartum. Peripartum is during labor, intrapartum is during deliveries. Then we are going to see about perinatal depression and neonatal encephalopathy. Perinatal depression usually lasting for 1 hour. Usually it's seen on first hour of birth. It will manifest as decreased mental state, hypotonia. Sometimes they will have disturbance in spontaneous respiration and cardiovascular function. Neonatal encephalopathy is a clinical syndrome of disturbed neurological function in earliest day of life, usually seen in term infant, which is manifest by difficulty in maintaining and initiating respiration and depression of tone and reflex and subnormal level of consciousness. Sometimes it's associated with seizure. We should know difference between perinatal depression and neonatal encephalopathy. Perinatal depression usually seen first hour of after birth. If it is persistent more than 1 hour, it is neonatal encephalopathy. In neonatal encephalopathy, it's often associated with seizure. Another most important definition is hypoxic ischemic encephalopathy. That means there should be clinical evidence of encephalopathy should be there, and also objective data should support hypoxic ischemic mechanism as a underlying cause of encephalopathy. That means they should have clinical evidence of encephalopathy and objective data should support hypoxic ischemic mechanism as a underlying cause of encephalopathy. Perinatal asphyxia definition is according to WHO, it is failure to initiate and sustain breathing. It is perinatal asphyxia definition according to WHO. That means failure to initiate and sustain breathing. According to National Neonatology Perinatal Database Network, divided the perinatal asphyxia into moderate, severe based on the ABBA score and breathing. If the ABBA score is 4 to 6 at 1 minute, or if the respiration is slow, grasping at 1 minute is moderate. If the ABBA score is 3 or less at 1 minute, or no breathing at 1 minute is severe birth asphyxia. According to American Academy of Pediatrics and American College of Obstetrics and Gynecology categorize the perinatal asphyxia based on all four following criteria. There should be metabolic acidosis and upward sort should be less than 3 for more than 5 minutes, which are associated with signs and symptoms of neonatal neurological dysfunction like seizure, encephalopathy, and tone abnormalities with evidence of multi-system organ dysfunction. Usually, perinatal asphyxia, multi-organ dysfunction will be seen. According to AAP, if you are diagnosing perinatal asphyxia means the following four criteria should present. pH should be less than 7, upward source should be less than 3 for more than 5 minutes, and signs of neurological dysfunction and evidence of multi-system organ dysfunction should be present. Commonly, we use AAP definition for categorize. For categorization of perinatal birth ulcer, we will use. After definition, we are going to see about causes and risk factors of perinatal birth ulcer. First, we are going to see about antenatal natal causes. The antenatal natal causes categorized into maternal, uteroplacental, and fetal. The maternal causes are which will responsible for impaired oxygenation and decrease oxygen delivery to the decreased blood flow to the placenta. The common causes are pneumonia, bronchial asthma, cardiac arrest, severe anaphylaxis, and hypovolemic shock. In case of placental problems, what are the placental problem will cause perinatal birth ulcer is placental obstruction, cord prolapse, uterine rupture, and hyperstimulation with oxytocic agents. And fetal causes are fetal maternal hemorrhage, twin transmission, severe hemolytic anemia, and cardiac arrhythmia. What the three factors will causes means if maternal problem will be there, then there will be decreased oxygenation. Because of that, the decreased blood flow from mother to placenta will happen, and followed by decreased blood flow from placenta to fetus will happen, followed by there will be defecting gas exchange. Because of that, there will be hypoxemia and hypercarbia. To prevent that, there might be increased oxygen requirement. These three mechanisms will responsible for the cause of perinatal birth asphyxia. If it is happen in maternal level or placental level or fetal level, finally, what will happen? There will be increased oxygen requirement. And postnatal causes of birth asphyxia, the most important causes is lack of timely initiation of resuscitation, ineffective resuscitation, and also sometimes the sudden cardiovascular compromise like pneumothorax and cardiac tamponades also will responsible for the causes of perinatal birth asphyxia. Among these, the most important causes lack of timely initiation of resuscitation or ineffective resuscitation. We saw antenatal and natal causes and postnatal causes. Natal causes are antenatal causes divided into maternal, placental, and fetal. All will have decreased oxygenation, decreased blood flow to the fetus, followed by they will have increased oxygen requirement. After causes, we are going to see about pathophysiology. There are three phases of brain injury is there. It described in three phases. They are acute, late, and tertiary phase. First, we are going to see about acute phase. It will happen within minutes of perinatal asphyxia, that means hypoxia and ischemia, which result in primary energy failure. That means ATP will be decreased. If energy failure happen means iron function will not be happen. Because of that, there will be accumulation of intracellular sodium, calcium, extracellular potassium, and also increased accumulation of excitatory neurotransmitters like glutamate, which is responsible for acute phase brain injury. In late phase, it will usually happen 6 hours to 15 hours of life. In this phase, decreased cerebral perfusion is restored and cell death is happened. Occur due because of oxidative stress and secondary inflammation, which causes further neuronal damage. In case of tertiary phase, which is usually seen on months or years, here the oligodendrocyte maturation and synaptogenesis was severely affected. The phases of brain injury is three phases. One is acute phase, second one is late phase, third one is tertiary phase. Primary phase, there will be primary energy failure will be there because of the iron pump impairs, which causes accumulation of calcium and excitatory neurotransmitter like glutamate. In late phase, the cerebral perfusion is restored and cell death like apoptosis has been started to happen, which is occurred due to reactive oxygen fishes and nitrogen fishes. Free radical will causes further neuronal damage. In tertiary phase, which usually seen from month to years, here the oligodendrocytes and cenatogenesis are severely affected. It is a flow chart showing the phases of brain injury. First, after insult, there will be primary energy failure, which will happen within the minutes of birth of the baby, which causes sodium overload and excitotoxicity. That means increase glutamate, which indicates immediate necrotic cell death. Over a period of time, reperfusion will happen. That time, the cerebral metabolism started recovering. Because of that, there will be increased calcium overload, will causes release of free radical, will causes secondary damage. Because of secondary damage, there will be apoptotic cell death will be there, which finally result in hypoxia brain injury. If you treat before secondary phase means there will be decreased brain injury to the baby, or else baby will have severe brain injury. It is prevented by giving therapeutic window like therapeutic hypothermia. So, indication to start therapeutic hypothermia is within 6 hours of life. If he is starting after 6 hours of life, the secondary insult will happen and cell death will happen. Baby finally will have hypoxemic brain injury. So, intervention should be done within 6 hours of insult. After phases of brain injury, we are going to see about patterns of brain injury. It is categorized into brief asphyxia, severe brief asphyxia, then prolonged asphyxia. Brief asphyxia means there will be transients increase in heart rate and mild elevation in BP will be there, and also there will be redistribution of cardiac output. That means diving reflex. Diving reflex means blood supply from the minor hormones like G80 and all from the blood, from diving, the redistribution of blood from splenic circulation to vital organs like brain, heart, and adrenal glands. In case of severe brief asphyxia, the diversion of blood flow to the vital deep nucleus sections of the brain does not happen. Because of that, they will have subcortical and brainstem nuclear defect will be there. Here, in brief asphyxia, there will be redistribution of cardiac output will be there, so there won't be more problem. In case of severe, the diversion of blood flow is decreased, which result in subcortical and brainstem nuclear injury will be there. In prolonged birth asphyxia, there is loss of autoregulation itself, which result in diffuse injury to both cortical, subcortical structure, which causes greater injury to neuronal population. Brief asphyxia means that the duration of insult should be less than 10 minutes. In case of severe, it should be 10 to 25 minutes. In case of prolonged asphyxia, is more than 25 minutes. Now we saw patterns of brain injury. It is categorized into brief asphyxia, severe brief asphyxia, then prolonged asphyxia. In brief asphyxia, there will be redistribution of cardiac output to the vital organs, that is diving reflex. In severe brief, the diversion of blood flow will be happen, but it is decreased. Because of that, they will have subcortical and brainstem nuclear injury will be there. In case of prolonged asphyxia, there will be loss of autoregulation of cerebral circulation itself, which result in diffuse injury to both cortical and subcortical structures. Based on the site of injury, the clinical features will be vary. If the cortical injury will be there, means there will be the seizure manifestation will be present. If basal ganglia or thalamus involved, means child will have irritability, posturing, and brainstem dysfunction will be there. If the injury over the parasagittal area means child will have hypotonia, weakness, especially upper trunk is involved, and also they will have difficulty in visual and auditory processing. The site of injury, based on the site of injury, the clinical features vary. Cortical injury will cause seizure. Basal ganglia and thalamus injury manifest as irritability, brainstem dysfunction. Parasagittal injury manifest as hypotonia and weakness. Along with that, they will have visual and auditory processing difficulty. Based on the hours of life, the clinical features of HIV will be varied. Within 12 hours of life, there will be decreased level of alertness and the child will have periodic breathing and respiratory failure. Sometimes they will have hypotonia and seizure. But after 12 hours to 24 hours, there will be baby will have more often seizure, ethnic swell will be there, along with this, weakness will be seen, upper limb involved more than lower limb in case of term baby, lower limb involved more than upper limb in case of preterm baby. After 22 to 72 hours, baby will have stupor or coma, respiratory arrest. Sometimes there will be severe intraventricular or periventricular hemorrhagic infarction will seen in preterm baby. After 72 hours, there will be persistent diminishing stupor and also the child will have disturbed sucking, swallowing, gag and tongue movements. From birth to 12 hours, child will have decreased level of alertness, periodic breathing or respiratory failure. Occasionally, child will have seizure. From 12 to 24 hours, there will be change in alertness, change in level of alertness, seizure. Sometimes weakness will be there. In case of term child, upper limb more involved than more lower limb. In case of preterm child, lower limb involved more than upper limb. If the child is, if the baby is 25 across to 24 to 72 hours means, sometimes they will have stupor, coma, respiratory arrest, and severe intraventricular periventricular hemorrhagic infarction in case of preterm baby. After 72 hours, there will be disturbed sucking, swallowing, gag and tongue movement, and also the baby will have hypotonia or hypertonia along with the limb weakness will be present. Then we are going to see about classification or staging of perinatal birth asphyxia. The staging name is star knot and star knot staging. It is consists of three staging: stage 1, stage 2, stage 3. In stage 1, parasympathetic system will be activated. In stage 2, sympathetic system will be activated. In stage 3, both system is impaired. In stage 1, the level of consciousness is baby will be hyper alert or irritable, and stage 2 is lethargy and comatose. The most important thing is the parasympathetic features like mydriasis will be there, and tachycardia will be there, GA motility will be decreased. In case of in stage 1 is sympathetic, stage 2 is parasympathetic. In stage 1, mydriasis will be there, tachycardia and normal or decreased GA motility will be there. In stage 2 is parasympathetic. There will be meiosis will be there, occasional apnea, bradycardia and diarrhea will be there. The most important thing is in stage 2, seizure will be commonly seen. In stage 3, child will be comatose and everything will be depressed. Respiration will baby will have apnea, heart rate will be variable, GA motility will be variable, and EEG shows in stage 2 generalized and low voltage will be seen in stage 2. In stage 1 is EEG is normal. In stage 3 is periodic pattern will be there and isopotential spaces will be seen in stage 3. The duration of symptom in stage 1 is less than 24 hours. Stage 2 is 2 to 14 days and stage 3 is fast to weeks. Outcome is 100% normal in stage 1. In stage 2 is 80% and stage 3 is sequelae will be there or death will be there. Outcome will be 100% normal in stage 1. In stage 2 is most importantly, baby will have diarrhea and seizure. In stage 1 is sympathetic stage, and stage 2 is parasympathetic stage. In stage 3 is both is depressed, both sympathetic and parasympathetic depressed. Then other classification is Levin classification. In this, the HIV is categorized into mild, moderate, severe according to consciousness, tone, seizure, and sucking or respiration. In mild, child will be irritable. Moderate, baby will be lethargy. In severe, child is comatose according to star knot stage. The most important is in moderate stage, baby will have seizure, and sucking and respiration is difficulty in severe staging. There are two classifications here. One is staging, one is star knot and star knot staging. Another one is Levin classification. Star knot and staging classified stage 1, stage 2, stage 3. Stage 1 is sympathetic system will be activated. Stage 2 parasympathetic system is activated. Stage 3 is both is different. In case of Levin classification, it is classified into mild, moderate, severe based on consciousness, tone, seizure, sucking or respiration. After classification and staging, we are going to see about consequences of birth asphyxia. Usually, perinatal birth asphyxia will causes multi-organ disorder affecting every organ system, including brain, heart, lung, kidney, and intestine. In term baby, most common system will involve is renal system, followed by CNS, followed by cardiac and lung dysfunction will be there. Renal system involvement will responsible for 50% of the cases. The extent of organ system dysfunction determine the extent of organ system dysfunction determine the early outcome of aspirated neonates. Why multi-organ dysfunction seen in birth accident is initially there will be diving reflex. So there will be diversion of blood flow to the vital organs. Over a period of time, prolonged birth accident will causes decreased blood flow to the vital organ also. That's why they will have multi-organ dysfunction. Among these, most commonly involved system is renal system. And also the extent of organ dysfunction will determine the early outcome of asphyxiated neonates. Then we are going to see about systemic manifestation. In CNS involvement, baby will have hypoxic encephalopathy, intracranial hemorrhage, seizure, and long-term neurological sequelae will be because there is decreased oxygen delivery to the brain, and also there will be increased excitatory mechanism will be there because of the seizure will be there. Sometimes preterm baby will have a intraventricular periventricular hemorrhage will be there. In term baby during difficult delivery, during the trauma during delivery will causes intracranial hemorrhage. Cardiac manifestation occur because of poor ventricular function. Because of that, there will be decreased cardiac output. Over a period of time, there will be congestive cardiac failure will happen. And the renal system involved because of decreased cardiac output and secondary to acute tubular necrosis will causes oliguria, hematuria. Sometimes there will be renal vein thrombosis also seen. Pulmonary involvement is seen because of if it is associated with sepsis or meconium aspiration or if the baby is preterm. Sometimes perinatal aspiration also is associated with primary pulmonary hypertension. If it present, na baby will have breathing difficulty in the form of tachypnea, chest contraction, that and all seen. GA involvement, baby will have necrotizing enterocolitis and hepatic dysfunction. Necrotic enterocolitis, why it is happened means because of diving reflex, there will be a distribution of blood from glandic circulation to vital organ. Because of that, there will be decreased blood flow to the intestine. In that meantime, if you are giving feed means there will be feed intolerance will be there. Because of that, baby will have NEC. Hepatic dysfunction will causes clotting factor defect. Because of that, baby will have coagulation abnormalities, and also there will be bone marrow suppression will be there. Because of the baby will have thrombocytopenia, anemia, and metabolic manifestation, baby will have acidosis, hypoglycemia, hypocalcemia, hyponatremia. Among these, most system involved is renal system is most commonly involved. The long-term sequelae seen in condition like CNS manifestation. Then we are going to see about investigation. First, we are going to do see about laboratory investigation, then imaging and EEG. Now, what are the laboratory investigation we will do initially means we will do CBC and CRP. In CBC, we will see leukopenia or leukocytosis. Sometimes thrombocytopenia will be there because of bone marrow suppression. If it features of sepsis is there, CRP and will be CRP become positive. And we will do ABG to look for any metabolic acidosis and increased lactate level. And there will be coagulation abnormality will be there. So we will do PT, APTT, INR. To rule out cardiac problems, we will do CKMB, troponin. So if needed, we have to do echo. We look for the ventricular function. If liver, to look for liver involvement, we will do LFT will do. We will look for if there will be elevated, there will be increased AST and ALT. To look for a renal problem, we will do RFT and electrolytes. There will be elevated serum creatinine and also child will have poor urine output, and also there will be decreased electrolytes like sodium, potassium, and chloride. That's it also associated with metabolic derangement. So should look for glucose level, calcium level, and magnesium level. Now, among these, most important is glucose because hypoglycemia will causes seizure. It will causes adverse outcome in case of perinatal asphyxia. So you should treat hypoglycemia as early as possible. If the child is having a features of sepsis, you should start antibiotic also. Initially, after the clinical examination, you do laboratory evidence. Lab values will do CBC, CRP, RFT, LFT, and coagulation profile will do. For to load metabolic derangement, we will do calcium and magnesium level. After laboratory evaluation, we are going to see about brain imaging. We will do cranial ultrasound, CT brain, MRA. CT brain is we are rarely do because of radiation. In CT brain, we can see only cerebral edema and cerebral hemorrhage. First investigation of choice is cranial ultrasound. In this ultrasound, we are going to see about any loss of gray or white matter differentiation, and small ventricle is there. And we are going to see among the most important thing is we are going to see about bleeding manifestation. Any hemorrhages is there or another, we can see by using cranial ultrasound. The investigation of choice is MRA. We can do conventional MRA if needed. Now we can do diffusion weighted imaging, MR spectroscopy, susceptibility weighted imaging, and MR angiography. When we'll do a conventional MRI means usually we should do out 7 to 10 days, at the earliest, at latest 14 days. Then only we can able to identify the injuries. If you are taking MRI within less than 7 days means no use in that. Most of the time the MRI will be normal only. That's why if you are doing conventional MRI means you should do what the 7 to 10 days of life or 14 days of life. If needed emergency means we can do diffusion weighted imaging, which shows abnormality within 24 to 72 hours, same like MR spectroscopy. There will be decreased elevated N-acetyl acetate and lactate will be there. The susceptibility weighted imaging when we will do not to look for hemorrhage, we will do. The MR angiography is done during evaluation of perinatal stroke. You should know brain imaging. In the brain imaging, initial investigation is ultrasonogram, cranial ultrasound. We have to look for any hemorrhage. It is insensitive initial few days. The investigation of choice is MRA. What are the MRA will do? The conventional MRA, diffusion weighted imaging, MR spectroscopy, susceptible weighted imaging, and MR angiography. After imaging, we are going to see about electroencephalogram, which is also called as EEG. There are two types of EEGs. One is conventional EEG, another one is amplitude EEG. Most commonly, we'll use amplitude EEG. It is a best procedure. What we are going to do means we are going to monitor the cerebral function. The advantage of EEG is amplitude EEG does not require any training. Normal person also we are able to use, and also most important thing is you use it for identifying and managing seizure, and also it is used for predicting long-term outcome of neurological sequelae. Advantage is it does not require any formal training. It's predict the long-term outcome, and also it is used for identifying and managing seizure. There are two types of EEG, sir. Conventional EEG and amplitude EEG. The most commonly we'll do amplitude EEG. Then we are going to see about management of HIE or perinatal birth asphyxia. Here we are initially going to see about supportive care. Then followed by we are going to see about neuroproductive stages like therapeutic hypothermia. First, supportive care. Immediately after birth, whether the baby is cried or not, have to look if the baby is not cried. Upward is less than 3 or more than 5 minutes, or a child is intubated means you can directly start therapeutic hypothermia. And the main thing is we should give the supportive care after resuscitation. We should maintain ventilation and perfusion. If the child is not maintaining saturation, we can give oxygen. So if needed, we can start CPAP or artificial ventilation. Like we can intubate the child and we connect the child to ventilator to maintain the ventilation. For perfusion, we should maintain the mean BP or maintain the if the BP is not maintaining, then we can start I will show you if the child is in short, we can give bolus. Even after that, the perfusion is not maintained, means we can start inotropes like dopamine, dopamine. After maintaining ventilation and perfusion, we have to look for the fluid status and blood glucose level. Here, perinatal birth also the most common systemic manifestation is renal manifestation. Because of that, there will be fluid overload will be there. That's why whenever you're giving fluid in case of HIE, you should restrict. There should be fluid restriction should be there, and also you should maintain the blood glucose level in. We should maintain the blood glucose level because it will determine the neurological outcome after HIE event. Because hypoglycemia causes seizure and will trigger the poor neurological outcome. So you should maintain normoglycemia and also you should restrict the fluid and also you should maintain the ventilation and perfusion. After maintaining blood glucose ventilation and perfusion, the most important thing is temperature. We should prevent hyperthermia. Hyperthermia is associated with adverse outcome. And also you should treat infection. If infection is there, means you should start antibiotic as soon as possible. That's why when laboratory evaluation, we'll do CBC and CRP. If CBC and CRP shows any features of sepsis or baby shows any features of sepsis, we should start antibiotic as early as possible. Another most important supporting care is seizure. Usually seen in stage 2 HIE, most commonly used drug and drug of choice is phenobarbital. Now we are going to see how we are going to control the seizure according to the manifestation. Once you identify the seizure, first what will you give is phenobarbital. It is a drug of choice. What is the dose miss? 20 mg per kg IV stack can be given over 20 minutes. After 20 minutes, we should reassess whether the seizure is there. If seizure is persistent, means we have to repeat phenobarbital, but here dose is 10 mg per kg per dose. Here 20 mg per kg dose will be given. Here 10 mg per kg per dose given. Maximum 40 mg per kg per dose will be given. Even after that, if seizure is persisting, means then we can go for the other drug is phenytoin. The phenytoin dose also same like phenobarbital. 20 mg per kg per dose. IV we should given over 20 minutes. We should be given under cardiac monitoring. Even after the loading dose of phenytoin, if the seizure is not settled down, we can repeat loading dose. We can repeat loading dose as a half dose. The dose of 10 mg per kg per dose. Even after that, if the seizure is persisting, we can use levetiracetam. Even after levetiracetam, the seizure is persisting, we can consider lorazepam or midazolam. But the drug of choice is midazolam. If the patient seizure is resolved with phenobarbital, means you should start maintenance after 12 hours of loading dose. The maintenance dose should be 3 to 5 mg per kg per day. Initial drug of choice you should know. If they ask me, they should tell the drug of choice for anticonvulsant in neonatal and infant drug of choice is phenobarbital. The dose is 20 mg per kg per day per dose. Maximum we can give 40 mg per kg per dose. Then we are going to see about long-term anticonvulsant management. When will you be anticonvulsant? You should do clinical examination and EEG. If the clinical examination is normal, means EEG is mostly not necessary. If both is normal, means we can stop considering phenobarbital. If the neurological abnormality is persistent, means we have to do EEG to consider whether to stop or continue phenobarbital. Based on your neurological examination and EEG only, we can stop anticonvulsant. Whenever it's stopping anticonvulsant, if the child is receiving more than one anticonvulsant, means the weaning should be done in reverse order of initiation. If the example, the child is on phenobarbital and phenytoin, means we should stop phenytoin first, then only phenobarbital. Then only phenobarbital should be in reverse order of initiation. This is the same what I told you according to Wayne's protocol. If the newborn anti-seizure medication like phenobarbital, perform neurological examination before discharge. If it is normal, means we can stop phenobarbital and discharge the child. If it is abnormal, means we ask the child to continue, ask the mother to continue phenobarbital for 1 month and ask them to review after 1 month. Then we will do in repeat neurological examination after 1 month. If it is normal means we can taper the drug over 2 weeks and we can stop. If it is abnormal means then only have to do EEG. If the EEG is normal, now we can taper the drug over 2 weeks. If the EEG is abnormal means we should continue the drug for another 3 months and reassess at 3 months of age. This is a common protocol we have to do. But once you started a AED or anti-seizure medication, before discharge, you should perform the neurological examination. If everything is normal, now you can stop considering phenobarbital. If it is abnormal, now you should ask them to review after 1 month. If 1 month is normal, you can stop the drug. If it is abnormal, you have to do EEG. The EEG is abnormal means you should continue the drug and you should reassess at 3 months of age. Then neurological neuroprotective surgery. The most important thing is therapeutic hypothermia. It is gold standard treatment for the infant with moderate to severe hypoxic ischemic encephalopathy. What it will do means it prevents the secondary energy failure. That's why we are starting therapeutic hypothermia within 6 hours of life. Because of that, there will be decreased cerebral metabolism, inflammation, oxidative damage, and excitotoxicity and cellular apoptosis. How will you do? There are two types of cooling method is there. One is selective head cooling, another one is whole body cooling. In selective head cooling means the cap will be there. You can place the cap over the head and place the baby over the warmer. In case of whole body cleaning means the cooling blanket will be there. You can place the baby over the cooling blanket. Most commonly, whole body cooling will be used. In whole body cooling, there are high technology device and low technology device are there. In high technology device, we'll use Tacodone and Meditherm will use. In case of low technology device, we'll use Miracradle. In selective cooling, we'll use Olympic cool cap system. This is an image showing Meditherm hyper or hypothermia machine. This is Olympic cool cap system. You can place the cap over the child. This is selective head cooling method. Meditherm is used in whole body cooling method. This is Miracradle. What is the selection criteria? As I told previously, the age of the child should be less than 6 hours and the gestation age should be more than equal to 36 weeks and the temperature during admission should be 36 to 37.4 degrees Celsius. Another most important thing, there should be evidence of perinatal asphyxia should be there. It shows any of one of the following. There should be decreased pH or in the form of pH less than 7 or base excess is more than 16 in cord blood gas or arterial blood gas within 1 hour of birth or Apgar score is less than 5 at 10 minutes of age or the baby required positive pressure ventilation for at least 10 minutes or if there is history of acute peripartum event like cord prolapse uterine rupture is there, means it indicate evidence of perinatal asphyxia. If anyone is present means the child is fit for treatment of therapeutic hypothermia. And also if there is evidence of moderate to severe encephalopathy present also, we can directly start therapeutic hypothermia. Before starting therapeutic hypothermia, we should know the selection criteria. There should be evidence of perinatal asphyxia and the evidence of moderate to severe encephalopathy should be there. The gestation age is more than 36 weeks and the age of the child should be less than 36 hours. What are the exclusion criteria? If the child is severe IUs or there is severe coagulopathy or major congenital malformation there means we can stop considering therapeutic hypothermia. The exclusion criteria is IUGR, coagulopathy, bleeding and major congenital malformation. What is the procedure? Before the starting procedure, first we are going to do counseling the parents and we are going to prepare the cooling system. Set the cooling blanket temperature at 33.5 degrees Celsius and you monitor and document the infant pre-cooling vitals and place the baby over the cooling blanket with only one pamper. There should not be cap, shirt, pant and socks should not be there. Only pamper should be there. After placing the child over the warmer. We should insert the rectal probe up to 2 centimeter in the infant. Once you set the target temperature at 33.5 degrees Celsius, you can keep cooling for around 72 hours. That means 3 days. Usually the secondary failure happens from 6 hours to 72 hours. That's why we are keeping cooling for around 72 hours. After crossing 72 hours, we should start rewarming. We should increase the core temperature by 0.5 degrees Celsius every hour until the child reaches 36.5 degrees Celsius. Once the child reaches 36.5 degrees Celsius, remove the patient from the cooling blanket and reactivate the radiant warmer and document the temperature with skin probe. There you should document the temperature with rectal probe. Here you should document the temperature with skin probe. The target temperature should be 33.5. You should keep cooling for 72 hours. Maximum, we should do rewarming for every 0.5 degrees Celsius every year until 36.5 degrees Celsius. Once the child reaches the temperature of 36.5 degrees Celsius, then you can reactivate the radiant warmer. This is the image showing therapeutic hypothermia. This is the target temperature, 33.6 degrees Celsius. Baby was placed in the cooling blanket. The child should be in the cooling blanket for around 72 hours. Gradually, we will increase the temperature. Once the child reaches temperature of 36.5 degrees Celsius, we can activate the radiant warmer. How therapeutic hypothermia will activate? What it will do now, if there is hypoxia and ischemic features means there will be automatically anaerobic glycolysis will be there, there will be primary energy failure, there will be secondary energy failure because of that, there will be free radical release will be there. What therapeutic hypothermia is going to do means it will prevent anaerobic glycolysis and also prevent activation of NMD receptor and it prevent increased intracellular calcium. And also it prevent activation of nitrous oxide. It act in 4 stages. One is prevention of anaerobic glycolysis, activation of NMD receptor, and activation of lipase and lipid peroxidation, and activation of nitrous oxide prevention. Because of that, child will have reduction of actions of brain injury and also it causes inhibition of apoptosis or cell death. Then we are going to see about complication of therapeutic hypothermia. The most important complication is cardiovascular and respiratory complications. Baby will have pulmonary hemorrhage, bradycardia, sometimes baby will have arrhythmia. Metabolic complications are hypoglycemia and hematological calcification, thrombocytopenia, coagulopathy, DAC, and this means disseminated intravascular coagulation. The dermic damaging complications are skin blood burn, sometimes they will have subcutaneous fat necrosis. Among these, the most important thing is hematological and cardiovascular complication. We should carefully monitor in the child in maintaining the cardiovascular and respiratory cells and hematological system because there will be already thrombocytopenia will be there and liver dysfunction because of that there will be coagulopathy will be there. So we should monitor the child carefully whenever the child in therapeutic hypothermia. The most important 5 mark is therapeutic hypothermia. We should read in label what is selection criteria, exclusion criteria, indication for starting therapeutic hypothermia, types of therapeutic hypothermia, whole body cooling, selective head cooling, then procedure, complication, that and all you should know. This is the most important 5 mark. Then we are going to see about predictors of your neurodevelopmental outcomes. If the following features present mean the child will have poor neurodevelopmental outcome. What are the means? Failure to establish respiration by 5 minutes of life. Observe is 3 or less than 5 minutes. Or onset of seizure in toddlers or refractory seizure of stage 3 HIE or inability to establish oral feed by 1 week or abnormal EEG or the EEG failure to normalize by 7 days of life. Abnormal imaging findings. If anything is present, means child will have poor neurodevelopment outcome. The neurodevelopment outcome is based on seizure, stage 3 HIE and abnormal EEG and abnormal imaging. If anything is present, the child will have poor neurodevelopment outcome. This is a predictor of poor neurodevelopment outcome. Then prevention. How will we prevent? birth asphyxia. There are three types of prevention. Is there. One is primary prevention, another one is secondary prevention, another one is tertiary prevention. Primary prevention is include health education and primary production. Here, what primary production will do? Will identify the risk in pregnancy, will resuscitate the baby accordingly. We can manage based on risk of the mother. So primary, if you are identifying earlier means we can prevent entering the child into secondary prevention. If the child enters the secondary prevention stage means we should diagnose such a condition and treat as early as possible. Identify the birth experience and treat promptly. If the secondary prevention is not done means in tertiary prevention what you have to do means physiotherapy and rehabilitation. We can limit the disability and we can do rehabilitation. Before going to secondary and tertiary prevention, primary prevention is most important thing. In this, you should do health education and you should identify the risk in pregnancy. Then secondary prevention is early diagnosis and treatment. Tertiary prevention is physiotherapy or rehabilitation. Then outcome and prognosis. In case of mild, the outcome will be favorable. There will be good prognosis. If it is severe, means there will be high rate of neurodevelopmental disability will be there and high rate of mortality will be there. And also, if there is persistent severe HI at 72 hours or abnormal neurological examination at discharge or persistent EEG findings at 2 days or more, it associated with increased risk of death or disability. And also, moderate to severe injury in MRI also associated with high risk of abnormal output. Moderate to severe injury, abnormal EEG persistent for more than 3 days, or features of HI present for more than 3 days, or abnormal neurological examination and discharge associated with increased risk of death and disability. Mild cases will have favorable outcome. After discharge, especially 2 week post discharge, we should do medical and neurological examination should be done. After that, we ask them to do examination 1.5 month, 3 months, 6 months, 9 months, and 12 months. Along with vaccination visit, we should do following examination. At 1.5 month, with the thyroid screen not done to your BRI not done, we have to do following investigation. In 3, 6, 9, 12 months, we have to do neurological examination and developmental assessment. Each in every child, those who have a perinatal Asphyxia, they should send to the high risk clinic. In high risk clinic, they should follow up regularly during immunization issue. So there should be a neurological examination should be done, developmental assessment should be done, and assessment of vision and hearing should be done. After 2 years, every year till 5 years, you should do neurological examination and developmental assessment. Why the follow-up is important means if you identify earlier, we can do early stimulation. We can prevent the disability like a CP child to prevent cerebral palsy. That's why in perinatal birth asphyxia, the follow-up is more important. According to the vaccination, we should do high-risk follow-up. What are the immunization we have to do? We have to do medical and neurological examination. We have to do the assessment of vision and hearing. If MRI is not done, means you have to do MRI. If the oil fail means then you have to do BARA. This is how you have to do follow up in perinatal birth asphyxia. Thank you.